Good afternoon to everybody. Welcome to all our medical practitioners who have joined us today for the webinar, Role of Dietary Proteins in Management of Diabetes. Today it happens to be the World's Diabetic Day. It is true that diabetes has taken over a center stage in our country as our national disease. 1 in 6 people with diabetes in the world are from India. We have 77 diabetics in our country. Anyway, here once again, China has beaten us. They have got 116 millions. Once diagnosed, management of diabetics unfortunately is fragmented. Drug therapy, no doubt, has improved a lot. We have oral hypoglycemic agents, insulin, etc. But the crucial one, the pathological problem which has caused diabetes, that is the diet, is missing. Dietary management, unfortunately, even now, is not taught to all of us in our medical colleges. And hence, there is a gap, especially when we come to the role of proteins in diabetics or the role of other dietary constituents. To discuss all these intricacies, we have none other than Dr. Bansi Sabu, an eminent diabetologist of international frame from Ahmedabad. Dr. Sabu is now in a dream post because he is a president of RSSDI. RSSDI is a prestigious medical association of diabetologists. It is not like any other association, doctors, but it's a well-attended, academically oriented, scientific meeting, a fantastic organization. He is now heading that. Dr. Sabu has a PhD from England. He's a fellow of American College of Endocrinologists, fellow of International College of Nutrition. He's also founder of Diabetic Care India. He is, in other words, walking and talking encyclopedia in diabetes, at least in India. Recently, he has also recoined a slogan, access to diabetic care for all, if not now, when? On Diabetic Day, we wouldn't have found a better speaker than Dr. Sabu. I request Dr. Sabu to take over the stage. Thank you, Dr. Sabu.
Thank you, Dr. Patki, for very kind words of introduction for me and for RSSDI. We know that this is an organization with more than 9,000 physicians who are practicing diabetes. They are part of it, and we do multiple activities under the banner of RSSDI. As you rightly said, that the treatment part, as far as the nutrition part of the concern, it has not been taught in our medical school, while there is a lot of improvement in therapy in last 15 to 20 years. And we are more of a therapy-centric approach had become more common to the clinician rather than a lifestyle modification approach. And in lifestyle modification, I will put the nutrition part and the exercise both. So what we are seeing, the most of the clinicians, they talk to the patient about yes, you have to change your diet, you have to change your lifestyle pattern, particularly exercise, but they don't talk much about it. And that is what is required today. And let me share my screen with few slides. So in the next 25 minutes, I'll be talking to you the diabetes management. Can you see my slides properly?
Yeah.
So I'll be talking about the role of proteins in management of diabetes and pre-diabetes. Today is the 14th November. It's a World Diabetes Day, which is celebrated from all over the world on the International Diabetic Federation. Today, our theme of this World Diabetes Day is access to diabetes care. It is from the International Diabetic Federation. Access to diabetes care is poor in many of the countries, particularly those who are with middle income or low income countries. As this year, International Diabetic Federation had come out with the data that out of 5 patients in the world, 4 are actually coming from the developing world. And the patients, these 4 are from low income countries or middle income countries. And there is the problem of access to the diabetes care. Here, access to diabetes care is not just the meaning of medication, whether they are not able to get the medication, but they are also not able to get a doctor who is practicing diabetes or someone who is expert in the field of diabetes. They don't get the care from those doctors also. And this is the reason we get a lot of complication in young age. Those who are having diabetes, they develop complication within 10 to 15, 20 years. And a lot of them develop or they die also in young age too. Diabetes is a group of disease characterized by hyperglycemia resulting from defects in insulin production, insulin action, or both. And this is what a definition of diabetes. The term diabetes describes a metabolic disorder of multiple etiology characterized by chronic hyperglycemia with disturbance of carbohydrate, fat, and protein metabolism resulting from defects in insulin action, insulin secretion, or both. So primarily a type 2 diabetes is a patient with having a insulin resistance followed by beta cell failure, so insulin secretion. But in type 1 diabetes, this insulin secretion from pancreas is completely off. The effects of diabetes include long-term diabetes damage, which can lead to multiple system dysfunction and failure of various organs. In its most severe form, which happens more often in type 1 diabetes or even sometime in type 2 diabetes when sugar levels are very, very high, they may develop ketoacidosis or non-ketotic hyperosmolar state, which may develop and which may lead to stupor, coma, or even in absence of effective treatment at that point of time. It's an emergency. It may lead to death also. As I already defined, that it's a hyperglycemia. But in other words, it's not just a glucose problem. Actually, it's a vascular disease. It is causing the problem in all blood vessels. Wherever the blood is flowing, this high glucose will flow all over the body, and this will lead to problem. And that's the reason now we call in diabetes definition, this is a hyperglycemia which leads to multiple complications, and it's a vascular disease also. This is an endocrine disorder because of a pancreas is an endocrine organ which insulin is in hormone with abnormal insulin production, with impaired insulin utilization, and that is what we call insulin resistance. The burden of diabetes is increasing all over the world. In last 20 years data, if you see, it has reached to the pandemic proportion. An IDF data, which is talking in 2025, it will become 333 million. But if you see this data, whatever they are predicting, actually we are crossing it much before. Much before means in 2025, this was a prediction which was done long back by International Diabetic Federation, but just before 5 days, the IDF has released the data that already we have 541 million people with diabetes in all over the world. If you see, this is the data which is talking about 388 million adults with diabetes. It is actually 2015 data where we had talked that in India we have around 77 million of diabetic patients also. The long-term effects of diabetes includes multiple complications. It starts with microvascular and macrovascular complication. Microvascular primarily is a retinopathy and a nephropathy. Retinopathy is an eye disease, and other eye problems can also have in a diabetic patient. But the persons with diabetic retinopathy, it can lead to even blindness too. Diabetic nephropathy in early stage, there may not be any renal dysfunction directly, but they have albuminuria, and then ultimately it may lead to chronic kidney disease, CKD, with a higher creatinine, and they may have all symptoms of uremia and have a chronic renal failure or end-stage renal disease. It's also a disease of foot where more of a neuropathy. Neuropathy is a combination of micro and macrovascular disease both. They are also at the risk of foot ulcer, amputation, Charcot joint because of autonomic dysfunction. They may have sexual dysfunction, GI dysfunction. So almost I can say each and every system in diabetes is get affected. We have more of a patient with retinopathy and nephropathy. From macrovascular, we have a more of a patient with heart disease. So I mean, these are the two which is a major problem, because before they develop other complication, many of our patients, they die of either cardiovascular disease or because of the CKD. Sorry. Diabetes is primarily of two types, type 1 and type 2. Type 1 is an absolute insulin deficiency, while type 2 is a primarily of insulin resistance. We also have one more variety of diabetes, that is what we call gestational diabetes. That diabetes occurs only during pregnancy. It increases as pregnancy advances. Normally, if we caught a typical GDM, it is first time detected maybe between 22 to 24 weeks. But once some of them are detected even at the first antenatal visit, then we have to find out whether it's a pre-gestational diabetes or a sugar or hyperglycemia is occurring first time during the pregnancy. So the other word which now we started using is HIP, which is known as hyperglycemia in pregnancy. So I mean, you have a three variety of diabetes: type 1, which is an absolute insulin deficiency; type 2 is a primarily insulin resistance followed by beta cell failure; third is a GDM, which is gestational diabetes; and fourth is a other varieties of type 2, which includes secondary diabetes, which includes drug-induced diabetes, which include other endocrine causes of diabetes also. Now, this is a autoimmune diabetes, which is a 1.5 diabetes, which is not exactly type 1, not exactly type 2, which we call LADA. It is a latent autoimmune diabetes in adults, but internationally it is not classified as a separate disease because they have autoantibody positive. It is also considered as a part of type 1 diabetes only, but as these patients are presented, and most of the time they are misdiagnosed as a type 2 diabetes, not as a type 1 diabetes, and that's the reason it is called latent autoimmune diabetes, because they are diagnosed as a type 2, but with the autoantibody positivity, or within 6 months or after 6 months, they may require insulin. But the definition of the LADA is they have autoantibody positive, and after the diagnosis or for minimum period of more than 6 months, they may not require insulin for the control of the sugar. The other, which is very interesting, is a diabetes of gene, or we call it a monogenic form of diabetes. It is MODY, maturity onset diabetes of the young. These are the young persons with diabetes who develops diabetes in the age of around 25 or 30, but they have very, very strong family history of diabetes. They're 2 generation, 3 generation, and multiple cousins of in their family, they may have the diabetes, and their diabetes onset is somewhere around 25 and 30. And this monogenic diabetes, because the one gene have a disorder, and that leads to a diabetes, which we call is MODY. It's again multiple varieties of MODY are there. So we call this from MODY 1 to MODY 13. We have now this genetic testing is possible in our country. There are multiple genetic labs which are doing this testing also. So now we need not to send the blood to outside the country, but there may be more possibility of more such genetic disorder. At present, we have almost up to 17. That's so sequencing of the gene is done only for 17 different type of gene, which can lead to MODY or maturity onset of diabetes. I will not go much detail of this MODY because it has not been done so routinely, but I will just say all the clinician, if you have a patient who is diabetes is diagnosed maybe below the age of 25 or 30 with a very, very strong family history, and they are, most of them, maybe initially control, or maybe for later on also they may control with the sulfonylurea. The important point is here their C-peptide is normal. They are not presenting like insulin deficient diabetes, and they don't have the even higher insulin resistance too, like the typical type 2 diabetic patient. So it's a slightly confusing whether they are type 2, whether they are type 1, or but a high index of suspicion is required to diagnose these patients with MODY. You must send the genetic testing because nowadays it is available all across the country. The third, which is very important, is pre-diabetes. Now, why pre-diabetes is important from clinician point of view? So from clinician point of view, the pre-diabetes also have all risk factor for macrovascular disease. The persons with pre-diabetes can also have the cardiovascular disease, increased risk of CVD or cerebrovascular accident. Even at the pre-diabetes also, sometimes they start developing microvascular complication, which is retinopathy, even neuropathy and nephropathy too. From a patient's point of view, or the person with pre-diabetes, the important point that at this point of time, diabetes can be further prevented. So from pre-diabetes, if somebody wants to prevent his diabetes, that he should not become full-fledged diabetic, that he can prevent his diabetes, and that particular stage where he is at IGT level or impaired fasting hyperglycemia, he can prevent his diabetes with lifestyle modification. So this is very, very important part of it. If I just talk about the genetics of diabetes, I told you that type 2 diabetes is actually not a monogenic. It is a multiple genes are involved in that. So it's not gene is responsible for diabetes. It is epigenetic factors which are more responsible for someone to develop a type 2 diabetes. For type 1 diabetes, yes, some genes are involved involved, but it is not again like that particular gene is involved and somebody is going to develop. Yes, a genetic defect is there where they are more prone to develop diabetes, but it's not like a one gene. Only a monogenic diabetes we can say is only specifically with one gene involved, and that leads to diabetes. So that is what we call is moody. Now, a typical Indian phenotype, which we call it thin fat Indian. The thin fat Indian, in compared to Caucasian population, we have a greater abdominal obesity. Even he may have normal BMI. Still, the central part of the abdomen or the BMI of these patients, in compared to the BMI, the waist circumference of these persons is very, very high, and they develop diabetes even at a lower body mass index in compared to the Caucasian. They also develop the diabetes even almost 2 decades earlier than the Caucasian, or even 15 years earlier to that. So compared with US whites, the South Asians are more likely to present with dysglycemia, dyslipidemia, more metabolic syndrome. They may have IGT or IFG or pre-diabetes or even full-fledged diabetes, and they develop even at a lower BMI also. So they need not to have the BMI of more than 30 or 35 to develop. And this is what we call as a typical Asian Indian phenotype or typical thin fat Indians. This is very interesting slide, which you can see that YY paradox. Even the Professor Yudkin and Professor Yagnik both have the similar BMI. Both were having the almost of the same age, but you can see here the body fat percentage of Professor Yodkin is 9.1 in compared to the Professor Yagnik, who looks much lean. Even with the 22.3 BMI, you can see he looks very lean. His BMI is 21.2, but the fat percentage in Yagnik is much higher in compared to Professor Yudkin. So that shows that we are actually highly insulin resistant. At even lower BMI, we have a higher fat percentage in our body. Now, this explains the Asian obesity, or we can say South Asian phenotype, which is very important because that is the reason for them to develop diabetes. It is also an underlying risk factor for diabetes because of early malnutrition or low birth weight child. So if we want to have it as a primordial prevention, I think first thing we should improve the nutrition part of female. We have to make them a healthy mom. They should have a normal birth weight child, and that will improve the future risk for diabetes or future risk of metabolic syndrome to those who are actually born with low birth weight or with higher fat percentage also. There is one more hypothesis which is given long back, almost 50 years back, 1962. James Neal suggested that exposure to period of famine during human evolution has resulted in selection pressure in favor of thrifty genotype, and that lead to highly efficient fat storage during the period of abundance. So this is exactly happening to us. I mean, we were having a very thrifty genotype of thing, and we are getting a lot of fat which get storage. And even now with the abundance, also abundance of the food, still that fat storage is increasing in our body. So in the current climate of food overabundance, the sedentary lifestyle, this thrifty genotype is suggested to lead a metabolically disadvantageous phenotype. So in spite of lower BMI, we have more abdominal fat, that is what we call thin fat Indian. We have more insulin resistance, that is hyperinsulinemia. We have higher levels of CRP. We have lower levels of adiponectin. We have characteristic dyslipidemia, which is low HDL, high triglyceride, high level of small and dense LDL, and increased susceptibility to type 2 diabetes and coronary artery disease. So BMI is a body mass index, but it's not a true index for someone to have that they will be having more chances of diabetes. Rather, we should calculate all parts of it. So anthropometric data is very important. Along with that, what was the birth weight, how the persons had gained the weight in his early age. Also, they all are very important risk factor for someone to develop the diabetes. And this is also important for someone to understand how diabetes can be prevented. So it is like that if someone have a BMI of even 23, but with a strong family history, or he is having more of abdominal girth, still the chances or risk of diabetes for that particular person may be very high, even with other guy who is BMI is 26, but his fat percentage is less, his muscle mass is better, he does not have the abdominal girth, which is not more, probably his risk of developing diabetes is less. So BMI cannot be, it's a crude indicator, but it's not a true indicator for to know that this is the risk factor for the diabetes. Rather, I will put more of abdominal girth is to be considered more of a risk factor for that. Now, to prevent diabetes or delaying the diabetes, a lifestyle modification is more appropriate. It is more, research has confirmed that the lifestyle modification can prevent the diabetes in the persons who are at the higher risk, or even for a normal person also if they change their lifestyle. Now, what lifestyle changes which can help these persons with pre-diabetes or persons who are at the high risk of developing diabetes? One important lifestyle change which they can do is a diet. The diet should not contain more of carbs. They should have more of fibers. They should have more of a complex calorie content carbohydrates. They should have less fat, and particularly they should have high protein. So high protein, high fibers, complex carbohydrate will make a right diet, and along with that, more intense physical activity. Now, physical activity, just walking is not sufficient. I will put that along with walking, there has to be muscle strengthening, there has to be some abdominal exercise, and some stretching, some yoga will help. So if someone can do almost like for 80-90 minutes, a right way of diet can prevent definitely diabetes. Not only the diabetes, even the cardiovascular disease and other non-communicable disease too. In a diabetes prevention program, a large prevention study of people at high risk with diabetes, development of diabetes was reduced by 58% over 3 years, and that is what the benefit of lifestyle modification. Now, managing diabetes, we all know that drug therapy and the insulin is the cornerstone, but it is the diet and exercise. And we put that there are 4 things which are important for a person with diabetes to control. One is the lifestyle modification, which include diet and exercise. Yes, oral anti-diabetic agent, insulin therapy, monitoring. The most important, one more important part of this component is the monitoring of the diabetes, which is very, very important. And all these pillars which are important, they are getting connected with the diabetic education. So other than the diet, exercise, oral anti-diabetic agent, insulin therapy, it is the monitoring and education of the persons with diabetes. They all are required to manage diabetes in a better way and to prevent the complication. Since our origin and problems are different, management too has to be different. And what that? The concept of energy balance, everyone has to understand. And I think now with a more of education through the social media as well as with the media, people have started understanding that energy intake has to be less in compared to that what we are expending, because the expenditure is slowly getting decreased because of our sedentary lifestyle. Most of the time we are in the sitting position. So I think energy intake has to be also decreased. But many of us, we know that energy intake is actually high, but sometimes we can't resist ourselves. So how we can change our diet? The diet is a basic part of management in our every case. Treatment cannot be effective unless adequate attention is given to ensure appropriate nutrition. Dietary treatment should also aim for a better weight control, providing nutritional requirement, allowing good glycemic control with blood glucose level as close to normal, and correcting any associated lipid abnormalities also. Dietary fat, as I told you, it should be between 25 to 30%. Protein intake has to be increased. Carbohydrate should be less, that is less than 60. But we are actually taking almost 70% of our diets come from the carbs. We are taking protein less than 10%, and our dietary fat is also more. So, I mean, that's the basic principle to change our dietary content of our diet. This is a simple plate method where carbs should not be more than 25%, or 1/4 of our plate should not be more than that. The carb should be there. Protein we should increase because that's only 10 to 15%. That should become almost 25%. And other dietary things is increasing the fiber content of also. The hidden hunger, we don't feel about it. We can't come to know without lab test. It is at cellular level. When cells are deprived of micronutrients for their biochemical actions known as hidden hunger, this can lead to lots of chronic illness and including low immunity. So this is a new concept in a nutrition management, is a hidden hunger that we don't feel about it, but this is the taste which we can have, and this leads to also many chronic illness including low immunity. So the hidden hunger will have also in the obesity. It will also increase hypertension, dyslipidemia, as well as in diabetic patients also. To know more about the proteins, we will have expert, and he will be talking more about the Dr. Ketke will be talking about more about the proteins, and then we will have discussion. Can I stop sharing here?
Yeah.
Just to add one thing that, if you must have seen some of the media reports that in our diet, actually protein is very, very less. And one thing which I always suggest to my patients, whenever you are eating, there should be a mindful eating and look for protein first thing. The first thing which we should look in our plate, where is my protein? So without protein, don't fill your plate and see where is my protein. Once you are finding that your protein had already covered 1/4 of your plate, then you start taking other things like carbs or the fibers and the other content of your diet. With this, thank you very much. And now I request for further continuation regarding the proteins in our diet.
Thank you, Dr. Sabu. It was a wonderful presentation. The slides are visible?
It is very much visible.
Okay. Okay. Dr. Sabu has told us quite a good amount of information about diabetes. He has told us various complications. He says it can produce diabetic nephropathy, and it can produce cardiomyopathy, etc., etc. So there are so many pathies which are coming in the way of the complications of diabetes. If you ask any Indian woman, she will definitely tell you one pathy is sufficient at home to create problem. If there are so many pathies coming together, you can just imagine what could be the problem. Dr. Sabu also touched upon regarding exercise. I definitely agree with him. Regular exercise, at least about 75 to 80 minutes per day, will definitely help us to prevent diabetes. Now, exercise, once again, is very easy to recommend to a patient, but it is difficult for him to practice. One example I give you, on December 31st every year, we make certain amount of resolution, saying that from tomorrow onwards, I am going to behave properly, I will spend more amount of time on constructive activity, etc. And then we also decide from tomorrow onwards, I'm definitely going to go for my walk and exercise. So the previous evening, we buy a nice shoe, and ordinary shoe will not do. You'll have to go for Nike or some other thing. You spend about 5,000 rupees and half pant and everything. On the 1st of that January, you go for a walk. Okay, you're gone, and then you are happy. On the 2nd of January, also you are gone. On 3rd of January, most of the places now in January will be slightly cooler. You would like to sleep for a little amount of time. And that time you say, anyway, I've gone for a walk for 2 days. Anyway, 3rd day, even if I take rest 1 day, nothing will happen. And that day we take rest and then get up only on the December 31st. So exercise will have to be advised to the patient as important as that of the drugs what we prescribe. So in the important thing that is going to happen in this situation will be what's the energy consumption also has been told in detail, the dietary activity, and then RSSDI has recently recommended that 15 to 25% of our dietary content will have to come from the protein. Let us try to understand why they are discussing so much about protein, why it is important. Hidden hunger has been already discussed. Now coming to this protein, what has been shown recently is 93% of us are unaware of ideal protein requirement for our body needs. Now it is known that at least 1 gram per kg body weight of protein, every one of us should receive it. 9 out of 10 Indians lack protein. This is very unfortunate thing, and this happens throughout India. Even people who eat vegetarian or non-vegetarian, hardly matters. Non-vegetarian, everybody is not going to eat every day, once in a way. So even in them, the protein content is less. So 80% of Indians have protein deficiency that has been revealed even in the recent studies. And next one, unhealthy food puts more Indians at risk of diabetes. It also gives rise to financial crisis for the parents. It's the father and mother who are going to suffer. The children are going to demand so many of the unhealthy foods. You can't prevent it. And unfortunately, nowadays, the parents are also enjoying this unhealthy food. Okay. Now, why this dietary protein is important in management of the type 2 diabetes? If you can provide 20 to 30% of total energy, what our body requires in the form of a protein, you are going to do a wonderful thing. Why? What are the reasons? One, it is going to help us in glycemic control. Then it is also going to help us in improving our satiety. If our satiety is improved, if you are feeling that you are eaten well, the excess amount of diet may not get imbibed in our body. And third, it is also going to help us in preventing the lean body mass during weight loss in the both diabetics and pre-diabetics. So try to improve the dietary proteins. That's the recommendation of Journal of Nutrition. Now the role of okay. Coming to the role of dietary proteins among persons with diabetes, a significant decrease in the percentage of HbA1c in participants who have consumed high protein diet could be commonly seen. That means if you are not going to eat proteins, HbA1c will not going to get improved because HbA1c happens to be high density lipoprotein. That means that this density is because of the proteins. If you have not taken enough amount of proteins, then HbA1c cannot improve. LDL and cholesterol, all other things are going to improve. So if you want to take care of your HbA1c, please focus on the proteins. And high protein intake also has been shown in diabetics to prevent metabolic control. Say, for example, including syndrome X, both physician syndrome X and the cardiologist syndrome X, both can be little bit controlled with the help of improving dietary protein so that the carbohydrate levels automatically are going to come down. So requirement will be anywhere between 1 to 2 grams of protein is generally recommended. Now, even if there is a compromise of the kidney, protein intake need not be completely stopped. This also we'll just try to see. Now, what are these proteins? Proteins are nothing but they are the sources of nitrogen in the diet. If we do not store extra nitrogen, the kidneys are going to excrete excess amount of urea. That means even glucagon secretion and insulin secretion are also stimulated by dietary proteins. Now, glucagon, please remember, though it might increase the blood sugar level, it stimulates urea excretion by the kidney, and GFR can definitely increase a few hours after eating an adequate amount of protein. That means if you are pre-diabetic, if you are going to eat adequate amount of protein, by which I mean 1 to 2 grams of protein per kg body weight, you are going to do a wonderful thing to your kidney. Your kidney will thank you because GFR levels are going to be improved. Now, what are the different proteins we have got? We have got different types of protein, starting from non-vegetarian diet and the vegetarian diet. Even if it is a non-vegetarian diet, the red meat, as far as possible, will have to be avoided. I'm not telling that stop it completely. It has to be avoided. Now, if you come to cow's milk, which happens to be a main source of protein, at least in India, has more phosphorus as compared. So it is going to help you a lot. Which type of protein? Once again, a common question that his patient is going to ask us. Animal protein, wonderful. But unfortunately, if it is taken excess because of sulfur and amino acids, they might, in the last stage, can produce animal protein. That means rather than depending completely on animal protein, part of it could be animal protein, other things could be plant protein. And plant protein may contribute to bicarbonate levels, may be associated with some toxins. Also, sometimes if it is taken very excessively, but it may improve the lipid levels. Dietary and nutritional approach in prevention and management of type 2 diabetes. BMJ has published an interesting article. Some guidelines continue to advise macronutrient quantity goals, such as European Canadian recommendation that 45 to 60% should come from carbohydrate. Unfortunately, our Indian diet is mainly based, either it is a wheat-based or the rice-based, etc. Now, regarding the diet also, people are in terrific amount of, I should say, misinformation or confusion. They feel that wheat is better. I can eat any amount of wheat. Please remember, our blood sugar is like a bank account. Your bank account is, the balance is going to increase only when you are going to put the money. Similarly, in our body also, blood sugar is going to improve when you are going to add the carbohydrate or the sugar. Now, this sugar could be anyone. It could be wheat, it could be rice, it could be anything. Any of these staple foods are going to contain carbohydrate. So that we should not increase more than 60%. And your bank balance also will decrease when you are going to withdraw. How to withdraw from our body? Only way is exercise, exercise, and exercise. Nothing else. And 10 to 20%, please try to put protein so that the carb can be decreased. WHO also recommend the similar thing. That's about 25 to 30%. They have brought down the calories of carbohydrate to around 35%, and they ask you to increase the protein and little bit of fat. 2018 clinical practice guidelines also are of the same time. They say 0.8 per gram of body weight should be recommended as far as proteins are concerned, at least minimum. Role of the protein in diabetic control will be, as I said, insulin secretion appears to be enhanced by specific amino acid, especially leucine. Now, in those dietary proteins which have got adequate amount of the amino acid like leucine or arginine, that is going to help in release of insulin. That could be beneficial if your diet contains adequate amount of proteins and along with that, the amino acids also. Milk in the prevention of management of type 2 diabetes has been discussed a lot in various articles. What do they say is increased dairy consumption has been linked to lower the risk of type 2 diabetic, at least in the population which has got high risk. So this will be definitely useful if your source of protein happens to be milk. In vivo anti-diabetic and biological activities of milk protein, especially the casein and the milk protein hydrolase rate, have been shown in experimental animals. What they have shown is the biological activity of milk protein includes a number of things, including vasodilation, including immunity enhancing activity, and more than that, it also has got adequate amount of anti-diabetic activity, which might help you from progressing from pre-diabetic to diabetic condition. Now, if you come to bovine milk protein, it mainly consists of casein, alpha, beta, and kappa casein. These things are present over there in milk proteins. Now, if you look at basic amino acid thing, look at here. The casein has got lysine, which is the highest, 6.26. That is going to help you a lot if you are pre-diabetic or even if you are diabetic, so that some amount of complication or some amount of rise in the blood sugar can be controlled. Now, if you look at the bioactivity of the casein, it has got two activities, nutritional activity and immune activity. Because of immune activity, you heard a lot about this during the pandemic of corona. The casein has got antimicrobial activity, antibacterial and antiviral. One of the study also has shown it has got a direct antiviral activity. It also improves immune modulation by improving your IgG and IgA. Now, coming to the nutritional activity, it has got adequate amount of essential amino acids which are required by your body. It is also going to help in calcium absorption. Now, what about the other macronutrients? Dr. Sabu was telling about the hunger, which is not even felt by us. Some of them could be micronutrients. One of them could be the nicotinamide. One's possible mechanism, how it is going to help in, it is going to help in DNA repair enzyme, which are produced in our body, that is going to help in activity of these enzymes and controlling C-reactive protein. Arginine, nicotinamide, and immunity. An interesting article has appeared from Pittsburgh. What they have shown is when these things were given in high-risk surgical patients, along with other things, what they found was their stay in the hospital was less, their infection rates were less because of the improvement in the immunity, mainly because of arginine, nicotine, and it is going to help in immunity. Now, casein in triptin light has got less amount of carbohydrates. It has got casein as well as casein fragments. They function as antiviral agents. They upregulate innate immune system. We have got innate and then acquired immune system. Both the things are going to improve by this casein. It also downregulates detrimental conditions such as sepsis. Additionally, this casein has been linked with innate immune system to adaptive system by activating and enhancing B and C cell mediated functions, including the pinocytosis that can occur against the viruses and bacteria. Now, one question which is commonly asked by the patients and everybody will be, what is the role of this protein in renal patients? It is known that in chronic renal disease, excess amount of protein will be detrimental. Does that mean no protein should be given or what? That's a problem which is faced by everybody. The presence of GFR less than 60 per ml, we are going to nominate that individual as a chronic kidney disease patient. And the presence of GFR less than 60 ml, more than 3 months with or without other signs of kidney damage is suggestive of chronic kidney disease, but this has to be confirmed by experts. Now here you have got various stages of kidney disease, CKD1, CKD2, 3 and 4, depending upon how much is the GFR. Now protein intake in renal failures, what has been recommended is in stage 1 to 3, when there is a very mild amount of the things, your intake could be 0.75, stage 4 to 5, 0.6, stage 5, one can go up to 1.2 to help the body. Why low proteins in renal failure patients? Because they reduce uremic symptoms, they reduce burden of toxin and increase insulin sensitivity in the individual. Never give higher than 0.75 grams of protein per day. So it is going to help in fighting the infection. If it is given in a calculated way by a doctor, then it will be definitely useful for these patients. Now, triptin contains about, each diskette contains about 1.5 grams of the thing. So what is recommended? You can give around 2 diskettes twice a day. That will be around 6 grams. The remaining protein, you will come to the patient from dal, milk, and whatever other things he is going to take. This will definitely ensure that some part of protein is definitely going to the patient. More than all these things, as Dr. Sabu said, the self-care in these patients is very, very important. They have to be conscious about their disorder. They need not worry. Medical advancement has been tremendous. The doctors nowadays have got a wholesome attitude towards the patient's treatment as such. The patients also should take care of themselves by regular blood glucose monitoring, body weight monitoring, foot care, especially if you have got a severe diabetes, then foot care, even if there's a small amount of injury, can lead to a lot of complications. Personal hygiene, including dental hygiene, healthy lifestyles, diet and physical activity. This, according to me, is very, very crucial along with diet and the drug therapy as such, and try to identify the functionality of our target organs. Regular checkup with the doctor will be definitely useful. Stopping of the smoking. Fortunately, smoking incidence has definitely come down in India, but at the cost of, I think, alcohol. So, dietary management of diabetes mellitus along with pharmacological therapy will definitely prevent diabetic complications. What new things are coming now? Apart from all these things, number of drugs are being discovered. Recently, there was an article, of course, the drug is still in the phase 2 clinical trial, where they have shown there is a complete remission of diabetes. God willing, if that is going to happen in phase 3 and phase 4 clinical trial, that will be wonderful. Now, coming to some of the endogenous substances, a lot of work is going on 2 substances. One is regarding the use of jackfruit powder. Jackfruit, a huge fruit, has got a jackfruit, and the powder of jackfruit has been shown to have hypoglycemic effect. In the sense, it is going to bring down your blood sugar. And second one is methi. Methi in various parts of India, including Gujarat, is consumed in an adequate amount of time. This has been put in idli, dosa, roti, and everything. Though it is bitter, it has got adequate amount of the soluble fibers. So if methi and jackfruit, if they are going to come together, that will be useful for our patients, I think. So friends, by taking all this control, we definitely can add years to our life, and we can also add life to our years. So dietary protein supplementation will be one of the good advantages thing as far as management of diabetes is concerned. I would like to thank all of you for your patient listening. If there are any questions, we will be happy to answer them.
Yes, sir.
Sir, one question I have received that is regarding whether every patient requires insulin or what.
No, it's not like that. All type 2 diabetic patients may not require insulin, but at some point of time, they may need it. So a type 2 diabetic patient, suppose getting hospitalized, a type 2 diabetic patient who is primarily not an insulin deficient, who is insulin resistant patient, but may require insulin to control his sugar, maybe for temporary period, like in hospitalized situation, or with the patient who is put on the steroid, or his sugar is very, very uncontrolled. But many of these patients are initially controlled with oral antidiabetic agents. And these oral antidiabetic agents slowly get escalated as beta cell failure is a progressive problem. And then they may require insulin also after 10 or 15 years of diabetes. But if someone can control the sugar early and aggressively with good lifestyle modification, along with some medication, many of these medication can control the sugar for a very long period of time, and they may not require insulin maybe for 20 or 30 years of diabetes also. So we have many such patients who can have a good control of diabetes without insulin. But type 1 diabetic patients, insulin deficient patients, definitely they need insulin for the control of the diabetes. But in both the situation, even if somebody is on insulin, because that's a common myth, some of those who are on insulin, they may feel that now if we are taking insulin, why can't we eat everything? Because now otherwise also you are on insulin. But that's not true, because still they have to continue to have a good diet control, particularly of high protein diet and with low simple carbohydrate. They should have more of complex carbohydrate and high fibers.
Sir, one more question I've asked. It's a very commonly asked question. Has the corona increased the incidence of diabetes in India?
So corona had actually unmasked the patients with diabetes. There are, as we know, that 50% of our diabetic population, they don't know they have diabetes. And suddenly, because of corona, either they were getting admitted, they were going to the doctors. The first thing which was checked, other than their complete blood count and CRP, the sugar level also. And this has increased the incidence, but it is not actually, it is unmasking. Then corona has also increased the stress level. The stress could be also one of the factors for them to develop diabetes. The third thing, some of the patients of corona, they were started on steroids. So now steroid will have dual effect. Those who were already on borderline diabetes, they were at the higher risk of developing diabetes. They developed diabetes. Those who were having diabetes, their sugar had become very, very uncontrolled, and they started taking the treatment from the doctors also. So indirectly, it will show that if there is an increase, incidence or prevalence had increased, but exactly we don't have the data that yes, it has increased. Yes, one more thing can also happen with the corona infection, because it has got the same ACE2 receptor which is also there at pancreas, and there is a possibility of even increased autoantibody, and that can lead to even beta cell destruction. So it can increase the incidence of because of this direct viral effect or with autoantibody, and not very high number of the patients may have this, but still there is an increased incidence of type 1 diabetes, or there is some increased incidence of diabetes because of this beta cell dysfunction.
One doctor has asked that a patient of his has got HbA1c is raised, but BSL, fasting, and PP, they appear normal.
So
Is it a non-diabetic?
first you recheck the HbA1c. Second possibility is there, which is very common. The patient might have come with the fasting and postprandial glucose level from the lab or with the glucose meter. So since last few days, he might have taken care of himself more with the diet control, and he may have the fasting and postprandial both looks very normal, maybe less than 120 or 130, and post meal maybe less than 160 or 80. But actually, in last 3 months, he had not kept in good control. It was a Diwali festival time. Maybe in lockdown, he might have taken more. So HbA1c gives you an average of last 3 months. And the random blood glucose or the fasting on postprandial gives you the value of that particular day. So that's a big difference. So we have to take care of both the things. They are complementing each other. And we should get the fasting post-meal glucose level along with the HbA1c also.
One more question, I think we'll be able to give the answer. Different natural proteins and purified protein as a refined protein, which one you recommend? I think we'll have to go for a natural proteins, which could be more useful because they will be having comprehensive amino acids, which will be useful for these patients. One more question is that, anything else you want to add, sir?
No. Very true what you said.
Okay. One more question they have asked is, what is the role of zinc in diabetes management as such? One of the micronutrient.
Yes, as in micronutrients, there are many papers which had published in favor of zinc, that this micro trace element is actually not taken in a proper amount because of our refined food which we are taking nowadays, and this may be one of an important component for increasing the diabetes, and also with the patient with diabetes, it could be one of the trace element which is responsible for them to have uncontrolled diabetes. But more such research data is required because there are few papers on chromium also. And what we recommend that all persons, whether someone is diabetes or non-diabetes with metabolic syndrome or without metabolic syndrome, should have all the trace element in their diet. We had also seen during COVID time that persons with zinc deficiency, there is a possibility. Now, these are all theoretical possibility, or on a cellular or mechanism, you can see the benefits of zinc and chromium. But in clinical practice, to prove all these things will require a lot of data, lot of randomized control trial data also, and a long-term data of all these things. But at present, what we believe that with recommended doses, which is recommended dosed by the government agency also, that in recommended doses, all these stress element one should have on a regular intake.
Finally, what is your recommendation to our medical practitioners?
So I will recommend for my regular practitioner that they should have a balanced diet, which will have all these trace elements. Other than that, a right proportion of a protein, fat, and the carbs. And the carbs should not be very much refined. It should be of more of complex carbohydrate. It should have more of fibers in their diet. And overall calorie content also should not be more. It should be in the range of 1500 to 1800, which most of us will need if our weight is around 65 to 75.
So thank you very much, doctor. We had a nice session, I think. Thank you very much for your time. Thank you.
Thank you, sir. Thank you.